Tamsin, that's very kind. Thanks very much. And thanks, Sam, as well, for helping to organise today. Nice to see so many of you all here. We've not got long, so I won't hang around. We're going to do a very quick whistle-stop tour of sleep and what it is and how it works, where it can go wrong, and then what we see additionally happening in people who might be coming forward with more complex presentations, like after they've sustained a significant injury, for example. And then I'm going to give you a load of data later. And we'll see some examples of the kind of situations that we see in clinical practice. And then I'll finish up very briefly with some of the things that we can do to help to manage those sleep issues that we often see happening after people have had a significant accident or injury. We all know this, even the best sleepers in the world are going to have a bad night from time to time. The impact of that sleep disturbance on us in the short term tends to be more psychological. We struggle with our mood and our performance. And also, when we start to not sleep well, that can persist. So you'll meet people who don't sleep well sometimes, and they've had that experience for decades, which is a real shame because we've got some really effective treatment strategies that have been shown to work for all sorts of people, even people who've had really significant injuries and accidents, and they can benefit really quite quickly sometimes. So the fact that we see so many people struggling for such a long time with their sleep is a shame, because we do have the technology and what's referred to as cognitive behavioral therapy for insomnia. I'm sure you've heard of CBT before. There's lots of different variations of it, and we have a version for sleep and insomnia called CBTI. And this is what NICE guidelines would tell us what to do to manage that sleep problem. And it's effective for 70% of people who engage with it. So we've got a great opportunity to intervene with people. And I'll come back to a little bit about that towards the end of this talk today. First obvious question is, how much sleep do you need? Now, I'm sure you've all heard the 8 thing before. If I ask you to stick your hands up and say, how many of you sleep for 8 hours? A few hands go up, but not many. Some people feel fine on 6.5, 7. Some people need more like 8.5, 9. You know, our clients know. I don't tell Marjorie how much sleep she needs. I don't know that. I cannot look at you and say, oh, you look like a 6.5er, you look like a 9er. I don't know that. You tell me. Now, if you need 6.5, we're not going to have to work so hard to find the sleep you need in a 24-hour period compared to the person who needs more like 9. If you need 9, you're going to need to get 9. Otherwise, you're going to feel rubbish. You give yourself 8 hours all the time, it's not enough for you. So making sure that you get the right amount of sleep for you consistently is really important. And the 8-hour thing is a complete myth. Only you know how much you need to get. So let's try and find that and get that for you. Of course, that very much depends on how old you are. The younger we are, the more sleep we're going to need. So we've got hours of sleep up the y-axis here in a 24-hour period. A newborn might sleep 16, 18 hours in that 24-hour period. As we get older through childhood, in the middle here is our teenage years. Once we reach our teenage years, our sleep requirement then is fairly set for the rest of our lives. That's the average there. Some short sleepers would be under that. Longer sleepers would be over that. The big changes in sleep are happening in childhood. Kids just need more of it. And the younger they are, the more they're going to need, because of the intensity of the learning that they're doing. We're born into the world, we know nothing. We have to learn everything. That's really intense. And I need lots of sleep to process that learning. So that's why children need more of it. Quite a lot of our work's with pediatric populations. We need to make sure the younger the child, the more sleep they get, make sure that's age appropriate. Because you meet parents of 6-year-olds who think that 8 hours is enough. And it's not. They might need more like 10.5, 11. You give a bunch of 6-year-olds 8 hours of sleep, they will struggle. They won't do well. They won't be happy. They'll be irritable. They'll be difficult to live with and teach. So that 8 thing's quite dangerous, really. Know how much you need. That's personal. You could be a short or a long sleeper, but also make sure our kids get more. And the younger they are, the more they're going to need. Okay, if I'm alive and I'm not in a coma, I'm going to be in one of 3 states of consciousness. I'm awake, sampling life, or I'm asleep, then processing what I've sampled during the day when I'm awake. And when I'm asleep, I cycle between these 2 different types of sleep. REM and non-REM sleep. I'm sure you've heard of REM before, rapid eye movement sleep, and non-rapid eye movement sleep. Now, if we look at all of these healthy younger people, that's all of us up here. What happens when we go to sleep is we drop rapidly down into a long period of deep non-REM sleep. The non-REM shown in the numbers here, light 1, 2, down into deep 3, 4. Then we cycle back up the other side, and instead of waking up, we go into a short period of REM, shown in that blue bar there. Then down into non-REM, REM, non-REM, REM. And we cycle between these two stages of sleep throughout the night. We get more of this deep non-REM in the first part of the night and more light non-REM and REM towards the back end of the night. Now, that's normal sleep structure, sleep architecture, we might call that. In health, that's what we're all doing every night. You've got to do that deep sleep first. Imagine your brain, my brain is a busy office. I have thoughts occurring to me all the time. And each thought I have in my busy office generates a piece of paper up here. Some bright spark a few years ago estimated that we make 32,000 decisions every day. I don't know who counted that. 1, 2, yeah, all right, but I do. I have a lot of thoughts occurring to me all the time. At the end of today, I've got 32,000 bits of paper in here. Now, I can cope with that. But if I miss a night of sleep where I process that out, this time tomorrow, I've got 64,000 bits of paper in here. I can't cope with that. It's too much. I have to tidy this office up. And that's what we think's happening in the deep non-REM sleep. Most of my brain, your brain, very quiet. Goes very quiet. It doesn't stop. You'd be dead if that happened. But it's very quiet. The exception is you've got your hippocampus right in the middle of your brain, essential for memory consolidation. And it's at its most active in the 24-hour period when we're in that deep non-REM sleep. So you go back to that office analogy, we can analogize that hippocampal activity is my secretary coming out and going through these bits of paper. Now, I've had a thought about Headway going to pay me £6,000 to talk to you today. Dream on. I've had a thought about a Coke can I've just seen blowing down the high street. I've had a thought about a guy who cut me up on the motorway when I was driving my car this morning. Paper, paper, paper. Now, when I go into that deep sleep tonight, my secretary is going to come out and say, look, £6,000 invoice, Dave. That's really important. You can't forget about that. Top of the in tray for tomorrow morning. Coke can blowing down high street. Don't need to remember that, Dave. Trash it. So if I do enough of this deep non-REM, I'm going to tidy up my office and I'm going to be a happy, functional Dave. But if I don't get enough of that, either my sleep's been disturbed, shortened, or some stressors knock me out of this deep sleep. That could be psychological distress. That could be eating before I go to bed and digesting my food knocks me out of the deep sleep. That could be looking at my blue screens all day too much, and that stops me getting into my deep sleep. It could be caffeine. How many of you are drinking coffee right now? How many of you drink coffee at 8 o'clock at night and then don't get your deep sleep because that caffeine, which is a stimulant, is knocking you out of your deep sleep? That's my job. What is interfering with you getting this good deep stuff? Because that's what we need. We do it first in the night because I've got to tidy that up. And anything which might stop me getting this is going to make me feel rubbish the next day. So I've got to try and find out what are the obstacles that are stopping you achieving that deep sleep. It could be something simple like drinking loads of coffee. Or it could be really complicated, like a massive trauma experience, which might need lots of therapy to help. But that's what I'm trying to get back. So I tidy up my office. It's the most important thing for us. It's why we sleep every night. Try and fight it. It's coming for you. You'll last 2-3 days maximum, and then you will be sleeping because you've got to tidy this up. It's why we sleep every night. And it's why we want to do this deep stuff early to tidy up. Organize the memory. All right, Dave, that's great. Cheers. Well, what's all this REM about then? When you go into your REM sleep, a different part of your brain is activated. Your amygdala, you might have heard of that, part of your limbic system. So I've got my cortexes up the top, just underneath my skull, and they're doing the high level thinking stuff. Underneath that, you've got your limbic system. Underneath that, you've got your midbrain, which is the hypothalamus and the hippocampus that we've just been talking about. Now, your limbic system is in between your cortex and your brainstem. and it's associated with emotional memory. So that's why your REM dreams, my REM dreams, they're really scary. They're really weird. They're really unusual. They're really violent sometimes. They're really erotic. They're way more than what I experience when my rational cortex is switched on. So we think that the REM sleep is about emotional reprocessing, emotional venting, if you like. Tonight, when I go into my REM dreams, I could safely pull that guy who cut me up on the motorway out of his car and punch him in the mouth. I can safely take all my clothes off and run down the high street. I can safely scream at my boss. I can safely have florid sexual incongress with Angelina Jolie safely in my dreams. But I'm not going to do that stuff when I'm awake because I'll get arrested or I'll get fired. So this gets a bit Freudian, this is this idea of emotional reprocessing, that life is stress. We get cut up on the motorway. I need to process that out. If I don't, I'm going to take it home, ruminate about it, have bad dreams about it. That's PTSD. And then I'm going to get anxious about driving in my car. And I need to drive my car because I've got to go to work. I know you're more than happy with the concept of a memory, but how many of you are happy with the concept of a forgettery? It's actually really healthy for us to forget about stuff. You were cut up on the motorway. If it happened last week, you remember it. If it was a few months ago, oh, it starts to fade. There was that time. What happened there? You're forgetting that, and that's healthy. Right. That essentially there is your core science of sleep. That's why we do this sleep thing every night. The massive link with your mental health status and your sleep status. Why we do the deep early to consolidate memory and what that REM's about. Emotionally vent, get rid of the angst of the day. As we get older, some things change, some stay the same. We still have regular cycling between REM and non-REM, but our sleep is lighter and it's more easily disturbed than when we were younger. So older people complain about their sleep more than younger people do. That's the aging process. Your sleep's controlled by your brainstem. It gets older as you get older. It just don't work so well. There's not much I can do about that. I can't drill in there and tweak it. I'd kill you. So there's not much we can do about that. So what I want to do is get your sleep resilient when you're younger. So then you graduate into older age with resilient sleep, less likely to have a sleep problem because aging is a risk factor for insomnia. We also have age-related weakening of the sphincter muscles around the bladder. So older people tend to get up more during the night to use the bathroom. Please put your hands up if you're using the bathroom in the nighttime. Okay, I can't see you, but there'll be loads of hands going up. This is really common. It's bizarre to me how people don't seem to join the dots between what they do at 8 o'clock at night and what then happens at 3 o'clock in the morning. 16 pints of Stella is going to have to go somewhere, Marjorie. You're not going to hang on to that all night long. Oh, yeah. Easy fix this. Just stop drinking in the 2 hours before you go to bed. You avoid your bladder. You're less likely to wake up in the night to use the bathroom. That is so common and so easy to fix. We could probably deal with 25–30% of sleep problems in the room today just by doing that. One thing insomniacs hate, it's the brokenness of their sleep. If you can consolidate sleep into bigger chunks, we like that. Now, it might be that some of these wakenings are brainstem. It might be that some of these are bladder. Now, brainstem is intractable. I can't manipulate that. But bladder, we can. Just stop drinking so much before you go to bed. Less awakenings, more consolidated sleep, better memory, better forgettery, happy, functional person. Right. That's your core science of sleep. There's a few other physiological things that can affect our sleep, like exposure to natural daylight and our circadian rhythms, which follow these 90-minute cycles, which control all sorts of things like our REM and non-REM cycling. It's following your 90-minute circadian rhythm, which we use an awful lot therapeutically. And I'll come to a bit of that right now. Looking at sleep now, where we have someone in front of us who's maybe had some sort of significant injury, that injury is impactive on their sleep, and their poor sleep then impacts on their ability to rehabilitate from the injury. So you get a cycle forward, cycle back thing going on here. We've got loads of additional problems that we might see with someone who's had a significant accident or injury on top of what we might see in more typical insomnia populations. There may be behavioral things going on, more physical and mental capacity issues. Fatigue is massive. Mood disturbances are huge. Impact on families can be huge as well. We may have pain. We might be less active, so we're not so tired at night time. Might be napping in the day, that's related to that. Certain medications have side effects which can be significantly impacted as well. Trauma symptoms like nightmares and mood disturbances in the day are very, very common. Routines can sometimes spin out. Recreational use of things can get in the way sometimes. Pain, twitchy legs and limb movements in sleep. These are dysomnias, which are not uncommon. 10 to 15% of the adult population get restless legs, but we see more of it in people once they've had significant injuries. And we're only really starting to learn about pituitary, particularly endocrinological changes in the brain. We're at the very early stages of understanding that as well. So all of these factors can be additional on top of what we might see in more typical insomnia populations when we have someone who's had some sort of significant injury. And there's more. How old are you when the injury happened? And what was your sleep quality like beforehand? Good sleepers beforehand tend to be good sleepers afterwards, and the opposite is true. Where and how severe was the injury or the infection? How long ago were you starved of oxygen at the time? What was acute and continuing care delivery been like? How many interventions have gone in? And have you got better quickly, maximally, or have you got better really slowly and minimally? All of these factors are extra things that we need to consider. That's the skill of us as health professionals in this area, is to try and get a really good handle on what might be happening for Marjorie, what might be happening for Terry. Where are they at right now? How have they got here? Now, what do we do to fix that in the future? We go into the literature, which doesn't tell us a lot. From the University of the Blindingly Obvious, we have sleep is often disturbed after a brain injury or stroke. Thanks, guys. Tell us something we don't know. We know that a lot of sleeping and napping behaviors is common, especially just after the accident in the acute healing phase, which can go on for some time. We know that CBT for insomnia, which I mentioned earlier, which is a psychological and behavioral set of interventions, nice guidelines. We know CBTI is effective in this group. I've been doing it with these people for 20 years. It really works. We also know that we see more sleep problems and sleep disordered breathing, that's sleep apnea, even at mild levels of brain injury, even at the concussion level. We know this costs a lot, not just to the individual, but to us more widely as a society. Rehabilitation costs and supporting someone with significant injuries over a long period of time is massively expensive. It has high individual cost and societal cost. We know that if you're not sleeping well and you're tired, it will take you longer to recover. So anything we can do to improve fatigue, which is massively common in this group of people, and improve sleep will enhance the rehab process. It will speed up the rehab trajectory. It gets people better quicker, and they're less likely to relapse if we pay attention to this. There's not a lot in the literature, but what's there is pretty clear on that. We should be paying attention to this. We've got the technology which can be significantly impactful and beneficial, improving people's lives more quickly and getting them to a place where they want to be. We need to measure people to get a good idea of what's going on. So we stick these things on people's wrists for a few weeks. These are called actigraphs. Here's your data later. I'm going to do a quick whistle stop through some of these. This is our healthy control participant. So just take a little mental picture of this. This is the data from 2 weeks. Each line along here represents one 24-hour period. Midnight on the left, 6 in the morning down this line here, midday in the middle, 6 in the evening, midnight again on the right-hand side. You see all these little black tick marks. This is activity levels. This lady, full-time working 38-year-old lady, very good routine, consistently getting up at 7 o'clock in the morning, Monday, Friday. Oh, look, there's a lie-in on Saturday and Sunday. Consistently going to bed about 10:30 at night, Monday, Friday. Oh, look, there's a Saturday night out there and a Saturday night out there. That's fine. Squash those 14 days into an average, and that's what we see on the right-hand side here. That's those 14 days compressed into an average. Midnight on the left, 6 in the morning, midday in the middle, through to midnight again on the right-hand side. Very low levels of activity during the nighttime hours. That little bump there is her Saturday nights. All right, that's fair enough. Big sharp upswing in the morning, activity levels fluctuating around during the day, a more gradual reduction in activity levels in the evening, back down to nighttime sleep levels. That is normal, healthy sleep. That's what you look like. That's what I look like, touch wood. Take a mental picture of that, and now we're going to have a brief look at some of the other situations that we've seen over the last 20 years, measuring people who've had significant injuries over that time. I've just cherry-picked a few. This is where it all goes wrong. This is an end-stage dementia client. There is no clear pattern here at all. There's no rest periods, sleep periods, activity periods that look in any way consistent. That average, this person is actually more active in the night than during the day. So-called day-night reversal, a complete loss of routine. The bits of the brainstem that are controlling that person's sleep have degenerated to a point where they don't work anymore, and that is palliative. 2 weeks after the device came off that client, they died. When you lose that core control stuff in your brainstem around your sleep, that's palliative. This is end game. None of you lot look like that. This is very much end of life situation. Okay, so we've seen a very good example and the worst. Now everyone else is going to look like they're somewhere in between here. Here we have a lady 16 years after her accident. Actually, when she's sleeping at night, she's flatlining. There's hardly any activity at night at all. Look at that. It's right on the floor here. But what we've got is a 4-hour window where she's consistently asleep. You don't want that. You need 7, 8, 9-hour windows where you're consistently asleep. So we've got a reduced window of opportunity, we'd say here. And it's purely because this woman's routine is complete chaos. When she sleeps, she sleeps. She's not feeling good because it's really chaotic. So it's very straightforward for this lady. You just tighten her routine up. I think you can see that quite clearly there. Here we've got this guy 2 years after having quite a significant brain injury. I look at this in Monday, Tuesday, Wednesday, earlies, Thursday, Friday, Saturday, Sunday, lates, 3 days earlies, 4 days lates, 3 days earlies, 4 days lates. Is this guy a fireman? Go to the case manager. Oh, no, he's not working. Well, what on earth is going on here? Oh, well, on Monday, Tuesday, Wednesday, he's got physio at 9 o'clock in the morning. So he gets up to go to physio. The rest of the week, he doesn't, so he lies in. There's 2 peaks in the morning there. There's a load of sleep disturbance there because he's messing around with his routine. He looks exactly like a shift worker. He looks like a fireman. Is this guy a fireman? 3 days on, 4 days off? And he's fatiguing. We'll see that again and again. These activity levels just deteriorating through the day. He clearly doesn't like getting up in the morning. So when he doesn't have to, he doesn't bother. So what do? Case manager, could we just shift his physio to the afternoon, please? Oh, yeah. Now we can tighten this routine up. That's all we did. Within 6 months, the guy's got his life back. He's moved out of his parents' house where he was dependent on them. He wasn't happy there. They weren't happy either. He was hard work. He was tired and fed up. 6 months later, he's independent. 2 years later, he's married his partner. They've got kids and he's got a life now. Purely because we were messing with him. Sometimes it's us as health professionals. Let's do things for people when they want to do them. Don't ask night owls to do stuff in the morning. They clearly don't like it. And when you leave them alone, they just revert back to what they're going to do anyway. So that's just a simple adjustment of when interventions go in. Here we got a guy really active, loads of action all the time. This guy's a wheelchair user. He's really highly active for someone who's using mobility aids. Loads of sleep disturbance, loads of challenging behavior. He was not a happy guy. He was difficult to work with. He was fatiguing, again, really disturbed sleep. Had this really intensive program been put in by the neuropsych, OT, physio, loads of excursions and trips out. I'm thinking we're pushing this guy too hard. He's really active for someone in a wheelchair. So we dial back his interventions. A month later, his activity levels massively stabilized, sleep much better. But what the actigraph doesn't tell you is this guy's a joy now. He's easy, he's friendly, he's happy. And all we were doing was outpacing him, pushing him too hard. Here we've got a client and a carer. Client hit by a car, significant injuries, wheelchair user, no communication, needs round-the-clock care provided by his wife, who is massively fatiguing. She's not getting enough sleep because she's staying up later than her husband to get him to bed and getting up earlier from her husband to get herself ready to get him ready for the day. So she's exhausted. You superimpose them. You can see how joined together these people are. She's not getting the sleep she needs. It was actually her data in the court which argued for overnight waking care for this guy to give her the rest that she needs. Sometimes carer data can be really, really useful. Don't forget about them. Measuring a pair together can sometimes be really useful. Here's a child, 7-year-old, looks very much like our healthy 38-year-old working woman, except sleep periods are longer. And I've had to adjust the y-axis here because kids bounce around a bit more. Very similar, though. Low levels of activity at night, lots of action during the day, good tight routine. Don't scientists get excited when twins turn up? Oh, yeah. Here we've got a chap, 6-year-old brothers, identical twins. One born first without issues, second child stuck in birth canal, starved of oxygen, born with cerebral palsy and some significant developmental delay. We wear these watches again as a dyad. They stick them on at exactly the same time, wear them concurrently for 2 weeks, not quite, slightly under here. Look at the difference. On the floor here. Break time football, lunchtime football, after school football. Yeah, that's great. Don't mind that. Lots of good action, lots of good sleep. Brother, massive amounts of sleep disturbance every night. But hang on, kid goes to sleep with brother, kid goes to sleep. They all go to sleep. Then we're waking up 3-4 hours into the night for 3-4 hours every night. Look at that. Major sleep disturbance, not just for him, but also for his parents. So what's going on here? Why? What's happening at 3 o'clock in the morning? 2 o'clock in the morning, 1 o'clock, midnight. Oh, well, we get him up because we don't want him disturbing his brother and sister. So we take him downstairs and play with him for 2-3 hours every night, and everybody's shattered. Right. Maybe we need to think about stopping this. So what do we do with those kids when we go back to those 3 tried and tested methods that have worked for time immemorial? Bribery, corruption, extortion. Kids will do anything for a sticker chart, for a Jaffa cake. So we positively reinforce, right? We coerce him. And we say, right, you don't wake mummy and daddy up tonight. We'll give you a sticker. You get 5 stickers on the sticker chart. By the end of the week, we go to the zoo. Hooray. Very simple and works very well with a lot of kids. That this here is optional. This is habitual. We've got into the habit of getting 3 or 4 hours of dedicated mummy time every night. We don't need that because we still sleep. Try and fight it. It's coming for you. If you weren't sleeping, little Johnny here, you'd be dead. So you are sleeping. Now we just got to stop this optional, habitual 3 hours of playtime every night. And we will just positively reinforce that with a reward system. Right. Clinically, this stuff's useful. You get good data about activity levels, routines, disturbances, where those disturbances might be. That's going to really help guide when we do things. Don't get larks doing stuff in the morning. Do it when they want to do it. Don't push people too hard, or sometimes push people a bit harder if they're just malingering on the sofa, not doing anything. Maybe we do need to drag them out a bit, but sometimes we can push people a bit too hard. So clinically, this is really useful data informing what and how we do things. From a case management point of view, you can monitor someone's progress over time. Get a baseline, do some interventions, measure again and see what's shifted. The guy in the wheelchair, much happier. and it's a good reference point between different treating health professionals. There's precedent. You might be familiar with the McLaughlin Singh case from 2013, where there was a significant discount ordered by the judge from the case management firm back to Lachlan because they failed to look at his sleep. So it's a good idea to do that. If you don't do it, it can be a bit sticky from a case management point of view. And from a litigation point of view, you are getting objective evidence. This is evidential. The courts love that. You get 5 experts in the room, you'll get 5 opinions. You give them numbers, they love that. This person's 20% less active than we'd expect. This person's disturbed to this point, this degree at night that they need waking care provision. The courts love that because this is evidential. It's not just opinion. So you're also facilitating the legal process as well. How much function has been lost, perhaps. Impact on activities of daily living, not just for the client, but also for the carer, informing whether or not we need those funding for nighttime care provision. It's cheap, it's easy, stick them on. It's helpful from a clinical point of view, from a legal point of view, and from a case management point of view. What do we do to fix it? We do CBTI. So when the dosages of medications going in, put in the stimulating stuff early in the day, the sedating stuff later in the day. Pacing's really important. Don't push things too hard. Schedule rest periods. We can identify when people are on and when they're off. So we can say, let's do some physio at 10 in the morning, but at 3 in the afternoon, we need a rest period. So we can inform that with these actigraphic data as well. Get routines nice and tight because sleep loves that. Getting activity levels right. Sometimes we got to push people a bit more if they're sat on the sofa not doing anything. Sometimes we got to dial them back if they're pushing themselves too hard. Natural daylight, melatonin production in the brain, really helpful for sleep. So let's do stuff that we'd normally do just outdoors. That's fairly straightforward. And get everybody around the table to design those interventions that are going to work for people. Get the data, examine the situation. Now we can get tailored bespoke interventions that are going to work for Terry or Marjorie. They won't be the same. Everybody's different. It's about doing a really good analysis of what's going on and then tailoring those interventions to the individual. Good routines, get away from anything which interferes with sleep. That's essentially what CBTI is doing. Put everything in that sleep likes and get rid of the obstacles. Eating, drinking, alcohol, interferes with that deep sleep and the REM sleep. So yeah, eat, drink, caffeine, fine. Just don't do it too close to bedtime. Get a comfy bed, block out the light. Make sure pain and other comorbidities are managed. Quiet, dark and boring in your bedroom. Spend time outdoors. Get away from the blue screen devices in there 2 hours before bed. Caffeine, alcohol, drinking, eating 2 hours before bed. Then you don't interfere. These obstacles don't then interfere with your ability to get off to sleep and stay asleep. Change the bedding with the season. Simple stuff. A lot of us this time of year, it's getting warmer. We start getting all really hot and sweaty. We don't think to change the duvet. Simple things to do, really. A lot of this is very straightforward. Sometimes it's the timing of it that we might need a bit more guidance on when we're working with people who are a bit more complicated. No fun stuff in the 2 hours before bed. Nicotine, caffeine, drinking too much, alcohol. We mentioned these. Getting the medications in at the right time, making sure pain's managed. Fairly straightforward things to do. Leads us to around about a 70% hit rate with people who we intervene with. I've been doing these actigraphic assessments for about 20 years now. We've measured and treated over 600 people, and we get about 70–80% hit rate. It's highly effective, and it makes a significant impact to that person's quality of life and their rehab trajectory. So we start off with CBTI, we modify it to dial it back for those, pace it in a bit more gently, do things a bit more slowly, gently. That's the modified bit. Here's some of the elements of those things that we will use. They're non-drug. The drugs are still there if we want them, but we got big side effect issues with them. So we don't do these first. We'll do CBTI first because it's non-toxic. You don't have the side effects, and it works for about 70, 80% of people who engage with it. So we do this first. The drugs are still there if we need them. And we absolutely consider sleep as a comorbidity. Don't ignore it. You could end up in trouble as a case manager if you do. And everything else you do will be difficult if you don't get their sleep sorted. It's straightforward to do. Spend a bit of time analyzing it, looking at it. Give us a shout if you need some help with that, and get your person better rested. Then they're energized to engage with you on the other things that you want them to do. Then they're motivated to engage with you because they're better rested. And if you've helped them sleep better, they love you. What a great way to bond with your client and keep them, not push them too hard, push them away. And that happens. So looking at the sleep stuff is a really good idea. Informing our interventions, monitoring routines, guiding when we do stuff, getting that evidential data for the courts, determining function dependency. Don't forget the caregivers. This will all feed into the litigation, the case management, and the treatment clinical processes. Get that data. It is so useful. There's a load of references here from today if you would like to dig into this in more detail. They're more general sleep references about sleep generally as we started off today's session. And then there's some more injury-specific data there or references there if you would like to get into these in more detail. As Tamsin said, this is recorded. And so you can come back to these, and we've shared the slides with Headway as well. So they'll be available for you should you like to come back and tap into this in a bit more detail. There's also this excellent book. If you are interested in digging into this and more, you can buy this off of online marketplaces. Finished just about on time, I think. Tamsin will keep us straight on that. So I might be able to take some questions now. Some people don't like asking questions in front of everybody else, which is fair enough. If you want to talk to us more confidentially, give us a shout here. Here's our contact details. We've just done a real quick 45-minute whistle-stop tour of our day-long talk that we do in complex conditions. So for health professionals out there in the room today, if you want to get into this in a bit more detail, do come on the website and look. We've got a day-long course that we do in this and a 2-day course that we do in CBT for insomnia, how to assess and treat using that. So these might be some other bits that you could be interested in. Give us a shout if you are. Thanks very much for listening. It's been emotional. Anybody got any questions? I think, Tamsin, you've got some Q&A there, maybe.
We do. We've got quite a few that have come through. Can I just start off by saying thank you to you, Dr. Lee, for delivering such a really engaging and really helpful session on a topic that I know will resonate with so many people in the brain injury community, both people affected themselves, but professionals as well. You brought some really brilliant examples throughout that whole presentation to bring some of that science to life for all of us. And particularly, I liked you bringing in some of that carer data as well, because that's something that's maybe not talked about as much, just how carer sleep is impacted. So thank you so much again for that. We do have a lot of questions. We are running slightly over time, so we will only have time for a couple of questions today.
If you want to forward the others on to me in email, I can answer them and respond, and you can share them back.
That's fantastic. Thank you so much for that offer. We'll go through a couple of them now. So Jonathan Brayshaw, firstly, thank you for some of the comments that you've shared so far as well with feedback. That's been brilliant. Jonathan's asking, returning to life has been a massive disruptor to my sleep, which was 10 to 12 hours. But since I've resumed most of the activities which I was engaged prior to the injury, now I find my sleep, my fatigue, and my insomnia are all over the shop. Sorry, the questions keep disappearing there. Also suffer of complex PTSD. So what do I do, and what should I ask my neuropsychologist and neuropsychiatrist for with regards to these specific areas?
Yeah, it's really tricky when you've got a multiple things going on there, Jonathan. So there could be some lifestyle things that which we might be able to tweak around to help with the sleep, but with the underlying trauma that really needs dealing with at the same time. So I'd be talking to your neuropsychologists, psychiatrists, and looking at. I don't know if this has been offered to you yet, but look for EMDR, eye movement desensitization reprocessing. Headway will have information about that on their website, I'm sure. If not, come back to us and I can put you in the right direction. Really very good psychological technique to deal with trauma. So we have to, in this situation, we do co-treatment, manage the sleep and the trauma. And in order to be successful, we're going to need to kind of do both at the same time. So that's what I'd be asking for right now, is look into a clinical psychologist with some specialism in neuro rehab who can do eye movement desensitization reprocessing, EMDR. They know what you're talking about. Look around for that. If you get stuck, give us a shout. I know lots of people who do that.
Brilliant. Thank you so much for that. Are sleep patterns different in neurodivergent brains, particularly thinking of ADHD and autism and the way they process information? Would you say they need more sleep in general?
No evidence for that. Brainstem is where your sleep's controlled. Neurodiversity is above the brainstem. So people with neurodiversity will still sleep, just like a black person or a white person or a Muslim or a Christian or someone who is gay or someone who is pained. All of that is above the brainstem. Essentially, at the brainstem level, we are all exactly the same. So the sleep in anybody is the same. But what you do see in neurodiversity is in some situations a bit more hyperarousal. And it's in order to get to sleep, we must de-arouse. All of us have to do that. So if I say to you, if you're asleep in 5 minutes, I'll give you £3,000, you're not going to sleep. Or if you're not asleep in 5 minutes, I'm going to come and shoot you. You're not going to sleep. Way too excited, right? So you have to calm this down. All of us, every night. If your brain's too active, you won't be getting off to sleep very easily. That's insomnia, active mind. And you see that a lot more in the neurodiverse populations, is the winding down is sometimes more of a challenge. So when we're working with neurodiversity, we'll pay a lot more attention to that wind down period in the evening. I mentioned the 2-hour rule earlier for a load of stuff. We might extend that to 3 or 4 hours even, and make a really nice graded wind down period to allow for that de-arousal to happen more effectively in people with neurodiversity. But people with neurodiversity still sleep. Brainstem.
Fantastic, thank you. Just a question about blue screens affecting sleep. Somebody said they don't think that blue screens did affect sleep. So any comments on that?
That's because they like using their blue screen all the time and they don't want to put it down 2 hours before they go to bed. So your brain makes melatonin in your pineal gland, which helps you to sleep. Melatonin is made by stimulating your retina with bright natural daylight. Lux, 300 lux in this room right now. Sunny day out there, 30,000 lux, like 100 times more light pressure outdoors. That's why our advice is go outside, because you get loads more light pressure, loads more melatonin, better sleep. Melatonin's made best under conditions of blue end spectrum light. That's the light you get out of the sun sky in the morning, early afternoon. Then you get a red shift, gets orangey reddy at nighttime. That red shift tells your brain it's evening, stop making the melatonin, it will be dark soon, get ready to release the melatonin. Signal stops, it gets dark, pineal gland releases melatonin, that's sleep promoting. That is caveman experience, right? That's what we've all evolved to do on this planet forever. These things, can't see it, it's gone all weird. There's a phone there. There it is. It's weird that. They emit light at the blue end of the spectrum. So if you're looking at them late at night, you're telling your brain it's morning, make melatonin, not it's evening. Now, we've got good data to suggest that these things really do mess with your sleep. So 2 hours again, get rid of these before you go to bed. Plus, you can talk to someone in real. I just want to look at my magic box. The whole world is in my magic box. Go doom scrolling. Kill me now. There's a lot of scary data in the sleep world. I'll just give you this quickly. Israeli study did a nice split middle, massive number of kids. They took all the kids who use their screens for 2 hours a day or less. They split out the middle, and then they compared those low-level users with those kids who used their phones for 6 hours or more a day. And they had loads of mental health sleep questionnaires with them. The difference between those two groups is absolutely terrifying. The conclusions are completely clear. If you want to be less happy, spend more time looking at that. It's indisputable. And we are starting to clock into this now. We're seeing a lot of increase in mental health issues, and a lot of it's being driven by addiction to phones.
Brilliant, thank you. I think that's really got some take-home messages for everyone, really, in terms of screen usage.
Yeah.
We've got a couple of questions here about supplements that can aid with sleep. So I'll just keep that very broad. And if you've got any information on that, that covers a couple of those questions that we've had come through.
Which supplements have people been talking about?
We've got a question about magnesium.
Nothing. Magnesium, no. There's no evidence for magnesium at all. Despite all the aggressive marketing out there, there is no evidence for magnesium improving sleep at all. It will distract you from the other things that might actually improve your sleep as well. So save your money on that.
Great. Thank you for clarifying that one.
Postman. Yeah, go on. Next one. Next supplement.
Vitamin D is the next one.
Yeah, vitamin D. Yes, that will. Hang on. Sorry, postman. He's a bit deaf. Vitamin D definitely does help you sleep. You need vitamin D to help you sleep. It's a precursor molecule to making melatonin and serotonin. So yeah, we do need vitamin D. It definitely helps us sleep. You can already supplement with that, or you can go outside and get some sunlight on your skin, or you can eat oily fish and leafy green veg, which is better. So this is another reason why being outdoors can help us, but you've got to be a little bit careful with sunburn.
Yeah, fantastic. Thank you. I think we'll have time for just maybe one or two more questions. Listening to a brain trust hypnotherapy sleep recording to help me get to sleep. Is this interfering with my sleep pattern? That's a good one.
We evolved on a planet for 10,000 years without hypnosis tapes, white noise generators, sleep robots. All that stuff is going to do is interfere with your sleep. You're going to go to sleep tonight if you de-arouse this. If you've got something in the room distracting you from that, then you're not de-arousing. You're paying attention to the white noise or the radio or the television or the whatever. The best guy I think I ever had, I can't sleep unless I've got the Hoover on. What were you going to do, Terry? Go on holiday to Thailand, go down to receptions. Like, can I borrow a Hoover, please? No, I don't think so. No, good sleep needs nothing. Bad sleep's going to get loads of attention. So these things which are purported to improve or enhance sleep, there's no evidence for them. And what happens is you drop to sleep, you go into that deep sleep. Then when you come back up the other side and you go into lighter sleep, that music, that telly, that noise wakes you up. And if it wasn't there, it wouldn't do that. So get rid of it. Look at a good sleeper. Do they need a white noise generator to sleep? No. Look at you. Poor sleeper. Yeah, but you've not been a poor sleeper all the time. You've slept loads of your life without any of those gadgets or gizmos. And in fact, if you want to get worse, just start investing in them, because they won't work. They make you feel worse. Oh, I'm a real sleep failure. I've tried everything. Now I have to get the next thing and the next thing. And no, you don't stop. It's coming for you. You can't fight it. Just let it happen and don't agonize about it, because that's arousing. You must calm to sleep. Yeah.
Brilliant advice again. Final question, I'm afraid, that we've got time for today, but can a private person buy and use the Actigraph and read the data?
Well, yeah, you could. They cost about £1,000. The software costs about £1,000. You could teach yourself to use them. Took me 3 or 4 years to do that back in the early 2000s. There's not many people around who are sort of trained and skilled in analyzing and interpreting the data. That is the trickier bit, and then providing the evidence-based treatments based on that assessment. So that's the skill. I mean, anyone could go and buy an ActiWatch and stick it on. It's just then how do you process and interpret the data and then inform treatment from it? That's the tricky bit. So the answer is yes, but I don't know how useful it would be for you without some expertise to help you process it, analyze it, and interpret it.
Thank you, very helpful. I had one final question. Is the forgettery a technical term? Because is such a great way of
Is it?
explaining the importance of sleep. So is that
I
the
like it. Yeah.
trademark
Yeah,
patented?
memory forgettery. Yeah, it's good.
Wow.
I'm glad you picked up on that because it's quite mnemonic, isn't it? That sort of sit in your
Hmm.
mind now and think, oh, actually, I'm forgetting stuff. And you normally think forgetting things is a bad thing. Or I've forgotten that. I forgot about that meeting or that social event or whatever. Oh, that's a bad thing. But actually, it's not. It's really, really important and really healthy for us because we get loads of stimulus coming at us all the time. A lot of it goes in subconsciously, and we have to process that. And that's what that REM's about. So, yeah, the forgetter is really important.